Good morning all. I'm delighted to welcome you to this session on understanding and tackling fragility. We're going to give a couple of minutes for colleagues to get online and join us. I'm just going to clarify a little bit about the rhythm of the session.
Live is good? Okay. Yeah. So
Francois,
we can. Actually,
Francois, I can hear you.
Okay, don't worry.
He didn't give any time to.
Francois,
so I was a bit.
Okay. He probably panicked.
Yeah, I mean, I'm sure he was. Yeah, I mean, they tried. They were.
So as you know, you can hear probably in the background there, we had a few technical issues just before the start of the session, but I think we're good to go. If we go to the second slide, Julia, I just want to say a little bit about our session. Really delighted to be able to welcome colleagues, as you say, working with us on this NIHR-funded Global Health Research Centre on Health in Situations of Fragility, examining this concept of fragility and its usefulness for us in our work in promoting the quality and access and efficiency of health provision. My name is Dr. Alistair Ager. I'm Director of the Institute for Global Health and Development at Queen Margaret University here in Edinburgh. And after I've given a few introductory remarks, I'll be handing over to Dr. Hajawouri from the College of Medicine and Applied Health Sciences in the University of Sierra Leone. Then Dr. Shadi Saleh from the Director of the Global Health Institute at the American University of Beirut will speak about our work in Lebanon. And then really delighted after the presentations, I will be giving a bit of a conceptual framing for our work. Dr. Wouri and Dr. Saleh will be talking very much through our empirical work in the settings of Sierra Leone and Lebanon. And then we have the opportunity for Reynolds Senesi and Rabia El-Shamai, both involved in policy issues and development and support for the health response in Sierra Leone and Lebanon respectively, to reflect from that policy perspective on the implications of the research and more broadly the framing and understanding of fragility and its impact on health provision. And then we are very eager to try to simulate as much as possible the discussion we would have had in Dubai if we had met as we had planned to do originally before the COVID pandemic. And so we want to engage with those of you that have joined the session to think about this concept, and Karen Diakonou from IGHD will be helping us think through some of the frameworks that we're sharing and engage you in discussion about that. I'll have the next slide, please, Julia. So this is the timings. Basically, the first half an hour will be our presentations about our conceptual and empirical work. Then we'll be inviting Reynolds Senesi and Rabia El-Shamai to respond to that. And then we'll have in the last half an hour opportunity for some participation and reflection with respect to this. I will pause at the end, just go back to that slide a second, sorry, Julia. I will pause briefly at the end of Dr. Wouri and Dr. Saleh's presentations, just for any clarifications of fact and any particular issues that you want to raise about them. But we'll largely keep discussion until that last half an hour period. Yes, the next slide, please, Julia. So these are the aims of the session, wanting to think about this as a conceptual concept, but its utility in planning services in the context in which we're concerned. So the next slide, please, Julia. Now, one thing which many of you who've been in other meetings with HSR will be aware of, in the session details that you joined on the portal for this session, which you must have come through to get into this Zoom call, you'll see that there is a Q&A and a discussion forum button. And we're very encouraging for you right from the off to place comments and reflections in that Q&A facility. So some of those we will come to back as questions, but we're also very eager for you as participants to share reflections as we go through and observations. And Karen and Julia are posting a link in the discussion forum for an activity that we'll use later. So please do be active throughout the session, and we'll try to engage you as much as possible. The next slide, please, Julia. So I just wanted to begin with some conceptual framing, and really the whole session is about interrogating this concept of fragility and really questioning whether it is useful to us, and if it is useful, in what way we can make it useful and helpful to us in our provision. there will be little doubt that the two scenes that I've got depicted here would by all accounts be considered as some evidence of a fragile health system for rather different reasons. On the left, it's a clinic that has been bombed in Gaza and reflects the impact of conflict on the provision of health services and the operation of health systems. And I think we are all familiar with the notion of fragile and conflict-afflicted states as one of the common ways that we will use this concept. But we also use fragility in relation to circumstance on the right-hand side of the page, which is actually in northern Nigeria, of a health system which is broken and non-functional through challenges of governance and financing and human resources. This actually is a drug store cupboard in a clinic that I visited, and clearly this is an indication of a fragility of the health system, which we know in West Africa was a significant contribution to the challenges of managing the Ebola outbreak. So we're looking at this notion of fragility not just as a descriptive label, but to see if it can help us analytically to actually address fragility in the provision of better quality health services. The next slide, please. So what we've been doing within the NHR Global Health Research Unit on health in situations of fragility, and we're really grateful to NHR for their support for this, has been a program of empirical work, principally focused in Sierra Leone and Lebanon, but also framing this, trying to interrogate this notion of fragility and try to understand if it can be of value for us across settings of fragility, but understanding actually what we mean by settings of fragility. And there's three particular publications or activities that I want to highlight on these next three slides that were part of our advocacy, our academic advocacy for thinking seriously about this concept. And so we had this editorial within the bulletin, which was alerting us to the nature of fragility. And the first paragraph that I've highlighted, drawn from this on the right-hand side, is that we know that circumstances that are classified as fragile states, that one use of the term, we know that these have a disproportionate representation of excess mortality, particularly maternal mortality and child mortality. And so that we know that there's a high association with extreme fragility and situations of concern in terms of health indicators. But as the second paragraph indicates, then increasingly we're aware that fragility is a phenomenon that is not just a property of a few listed states, but rather something that affects a broader range of circumstances. And with the OECD using this framing of political, societal, economic, environmental and security dimensions of instability, which is the way it's matured to understand this. Clearly, there are elements of those contributions of stability in many, many contexts. And almost half of the countries that meeting the criteria for fragility through that OECD framework are now middle income countries. The next slide, please. So fragility is a concept that is being more broadly used across a broader range of contexts to depict some of the challenges in the delivery of health systems. And the first paragraph here is addressing a concept that we've pushed, I think, with empirical justification from quite early in our work together about this being a systems issue, that fragility is a phenomenon of a system. We were struggling a little bit 5 minutes before the hour at the beginning of this meeting, where the system of Zoom and the portal, it exists, it's there, but it was not quite connecting in the appropriate way. And we were struggling to be able to deliver anything that we had prepared because of that fragility, if you like, within the system. It's a system that was the challenge there. All the parts were working effectively, but they were not connecting usefully in an appropriate way. And using that as an analogy, we're mindful of significant evidence that we can identify elements of fragility within the health system. We can identify elements of fragility within communities that are affected by war and forced migration, and we'll be discussing some of those examples today. But we can also see evidence of fragility in this contract or this relationship or this trust between the public health system and between communities' needs. And that's one of the systems elements that we think is really important in understanding the notion of fragility. And then the second paragraph there just reflects our understanding that we are beginning to understand more effective ways of understanding systems behavior and interacting and intervening in complex adaptive systems. and using some of that conceptual language may be able to help us to adjust to the prevailing drivers of fragility. The next slide, please. And the third part of our advocacy, and this reflects on a paper that we published in Health Policy and Planning and blogs around that, was to note that in our empirical work, and this will be flagged a little bit in the next two presentations, that systems framing has led us towards adopting one particular methodology fairly frequently. It's not the only way we've been using to collect data, but using participatory group modeling as a way of working with communities, with health workers, with health policymakers, ministries of health, in a similar frame to begin to see where the breakages are in the system, where the fragilities are within that system, where the pressure points are. And with respect to the second paragraph highlighted there, not just to analyze and to reflect, to note fragility, but to think about forms of service design and community engagement that could prove durable and effective in those circumstances. So it's very much with a view, a very pragmatic goal of understanding what sorts of service models and service provision can support effective service delivery in these contexts of systems that are being challenged and broken and strained by prevailing circumstances. And the phrase right at the bottom of the page there just flags that it may be that some of the building of the health system and the relationships between service providers and communities may indeed address some of the drivers of fragility itself. Next slide, please. A final paper that I want to highlight just in this conceptual section is this review on fragility that was published in Health Policy and Planning in 2020. I just mentioned that earlier on. I'm not going to spend time going through the detail here. You're very welcome to consult that paper. But there were 5 themes that emerged from that synthesis that we particularly note. And I want to draw attention to the final 2 because they're relevant to some of the analysis that we're presenting later on. And so although we see that the word fragility is being used increasingly in context of understanding the challenges of health service delivery, there are 2, the 4th and the 5th elements, that are particularly pertinent for us. One is that financing and governance challenges are at the core of health systems fragility. Now that may be as a result of conflict and it may be a result of weak states, but there may be other drivers that are meaning that financing and governance issues are contributing to a challenge to the health system, which represents a form of fragility. And then the 5th point is that across settings, we do have increasing, I think, empirical validation that fragility consistently references breakdowns of this interface between the community and the health system, which encourages us to think of what are the service models, what are the ways of intervening that create a bridge where that friction or that gap has arisen, that we might be able to bridge those tensions and those breakdowns to create more effective interventions. The next slide, please. So towards the end, when we hand over to Karen, and we'll be talking a little bit about this framework, which I just want to close with before I then pass on to Hajar, is that clearly when we're thinking about fragility, there are a number of contributing factors to that. And we've just used on the left-hand side, the language of the OECD, the landscapes of risk, environmental, economic, societal, political, security-based, which are impinging upon health services. And we are aware of a number of domains, next slide please, of the health system that are impacted by those forces. And we'll go through some of these a little bit more in detail. And I'm not going to go through each of those at this point now. But in our framing and relating it to point 4 and point 5 previously, if I have the next slide, please, we can see that there's one particular pathway that we think is of particular interest, and this is a particular fragility focus on political economy and financing for health service delivery, where we see state capabilities and resources and the capabilities of the wider health system are influential. The equitable, affordable quality offer is influenced by those. Community trust is part of this, and obviously that then has an influence on population health and well-being. So that pathway of fragility, which is about at the fundamental level of the governance and financing of the health system, is a particular area of consideration. And then the next slide, please. Another one that particularly is the focus of the presentations we will talk about is the service models and the ways of bridging to the community's more effective services in the context of fragility. And some of those domains in the middle are still relevant, but now we're talking about the capabilities and resources of communities themselves and how those are brought in, and models for the timely and equitable utilisation of health services. So we'll be going back to that model a little bit at the end of the presentation. Next slide, please. So that's the framing that we'll be using, and it'll be a reference point, but now it gives me a great pleasure to hand over to Hadja Wouri, who will be talking about our work in Sierra Leone. Thank you, Hadja.
Good morning, everyone. Thank you, Alistair, for that very comprehensive introduction to the work we've been doing. So I'm going to be presenting the work that the RUHF project has been doing in Sierra Leone. I just wanted to start off by giving you a brief background on NCDs in Sierra Leone. So the literature shows that, and also estimated by WHO, that the percentage of deaths that can be attributed to NCDs in Sierra Leone is increasing from 18% in 2008, and it's going up to 26% in 2012. And the associated prevalence of risk factors is also substantive and also increasing. And in the context of Sierra Leone, if you bear in mind that this is a fragile context where we have additional burden and competing priorities with other disease conditions, we are dealing with a problem in an already overstretched health system. So on the whole, the problem about NCDs, it's recognized as a priority, but then the measures to address this burden, as we have seen in our research, is quite limited. Next slide, please. So the RUHF project in Sierra Leone, we had two phases. We had the scoping phase, where we tried to understand what were the multi-dimensional aspects of fragility that affect NCD burden from the health system perspective and also from the community perspective in Sierra Leone, and also to understand what were the health system challenges and the opportunities this will present for NCD prevention and control in fragile settings. So in this scoping phase, with the approach that we use was to conduct scoping reviews to find out what's already obtained on the ground, what can we understand. And then that in turn informed how we conducted our key informant interviews, speaking to the relevant stakeholders at the national level and also with health workers, so service providers. And then for the community perspective, we also engage in a participatory method known as group model building, where we engage with community members, so service users and caregivers, to try and understand how they navigate through the health system to get care for NCDs. And collectively, the findings from these methods help us to design evidence-informed interventions that we implemented in collaboration with the NCD directors at the ministry and also other relevant stakeholders. Next slide, please. So the key findings from the scoping review, we looked at the national policies for NCD care and prevention, and we identified gaps, which gave us some insights concerning the government's political will in terms of the policy implementation. So there was a policy and strategic plan, which on paper it was there, but then implementation was a problem. So effective implementation was a problem. It was faced with a number of challenges. And that created potential opportunities within the current health system reconstruction phase that we're currently engaged in to ensure that NCD prevention and control is integral to that process. And also with the policy that we had then was coming to an end, it was to be reviewed, and it also created a window of opportunity for that review process to be informed by evidence. And I'm happy to report that a new policy was rolled out in February of last year. A new NCD policy and strategic plan was rolled out last year, and this was informed by evidence. Some of the rough findings were fed into that process, and it was a highly consultative process as well. Another key finding from the scoping exercise was that there's limited data on interventions or services delivered targeting NCDs, particularly at the secondary and tertiary level. And the barriers to NCD service provision and utilization included inadequate healthcare professionals, financial resources, and low levels of knowledge and awareness of NCDs in general. Next slide, please. And then we engage with the communities using the group model building exercise, and the key findings was that there was adequate basic knowledge of the causes and symptoms of the common NCDs, and their confidence in public services was undermined due to lack of diagnostic facilities and medicines. Narratives and care seeking were very complex, and they were influenced by supply side factors such as proximity to the providers, cost, previous experience of care, but also quite disease specific factors, such as acute presentation, and then social-cultural factors as well played a very key role, such as personal and community beliefs about how appropriate some of these strategies were to address whatever condition that they were presented with. So on the whole, it showed that their care-seeking strategies included a combination of traditional, biomedical, and formal and informal providers. So there was a mixture, and some of these findings were presented and were published in the paper that I have highlighted there on the slide. Next slide, please. And a key finding that we got from the community engagement was that traditional leaders dominate the care-seeking pathways for patients, particularly in rural communities. So we did the GMBs in both urban and rural communities, but it showed that our findings showed that traditional healers dominated the care-seeking pathways for those in the rural communities, where access to services and availability of trained personnel is an ongoing challenge. The primary healthcare, the periphery healthcare units encounter NCD cases, but then they have drug stockouts, lack of essential diagnostic equipment at this level, and it makes NCD management very, very difficult and very unlikely. As a result, the community's confidence in these services is undermined, hence why they navigate through the traditional systems. And if you take into consideration the socio-cultural beliefs and the norms, it wasn't quite surprising that they gear towards traditional healers. And it was quite interesting to note that even when they go to traditional healers, sometimes it's quite costly compared to coming to the formal health sector. But because of these factors that I have mentioned earlier, it was quite easy for them to access traditional providers as opposed to the formal health system. Next slide, please. And then we also had some insights from key informant interviews. So a key finding that came out of that was that NCDs is increasingly recognized as a priority in the wider health system strengthening process. However, prevention and control together with the capacity to address this growing concern is quite low. And 4 main issues stood out: the political will in terms of financial support, budget allocation to deal with NCDs is quite low. And as I mentioned earlier, the lack of essential diagnostic equipment and medicines also poses a serious problem for NCD management and control at all levels. There are reports of stockouts at district and facility levels, and also at the primary healthcare level as well. The national guidelines and standards of care for NCD prevention and management were not available. Training and awareness of NCDs among healthcare providers was poor, and it's quite common for multiple actors to be involved, delivering a mixture of different training to healthcare providers. Next slide, please. So taking all that into consideration, these findings, we had a meeting where we brought all the stakeholders and the NCD director of the ministry, and presented our findings, and collectively we co-developed what were the suitable interventions informed by what we had gathered from the exploratory phase. So in the intervention phase, we together with the stakeholders, we embarked on developing a primary healthcare NCD desk guide to identify one of the gaps and needs identified in the scoping phase. And this guide was designed to identify, diagnose and treat NCDs. It was prepared by thoroughly reviewing current guidelines from WHO, systematic reviews and other relevant literature. And as I said earlier, it was done concertedly with the NCD technical working group at the Ministry of Health and other relevant stakeholders who were quite active within the NCD space. So VSO partners in health and also health workers, so doctors and CHOs. This was piloted in one of the districts in Sierra Leone, Bombali district, and we use a training of trainers approach, so it's sustainable. And over a period of time, we have also provided supportive supervision to see how impactful this desk guide has been at the primary healthcare level in managing NCDs. And then we also designed another project on social mobilization, and this was designed to promote community ownership and leadership. Again, through a sustainability lens, we're working quite closely with the social mobilization officer who sits within the district health management team within the district that we're doing this work. So again, Bombali district, to ensure that the work that we do, we co-create these messages with the social mobilization officer involved, with the communities, giving the communities ownership and leadership in this process to ensure that it is sustainable. Next slide, please. And that's where I hand over now to Lebanon. Thank you.
Thank you so much, Haja, for keeping to time. I don't see any questions at the moment in the Q&A. I'm just checking with Julia that that's the case, but we can obviously post questions to Haja a little later on. So I'm very happy to hand over to Shadi to talk about the work that we've been doing in Lebanon. Thank you, Shadi.
Hello, everyone. Thank you, Alistair. The discussion today, at least in this component of the session, is on fragility and its impact on mental health in Lebanon. It's also a pleasure to have Dr. Rabia Shammai, who runs the mental health program at the Ministry of Public Health, who will be also contributing his viewpoint later in the session. Just to give a little bit of background on Lebanon. Lebanon is a small country located in the eastern part of the Mediterranean Sea. Something significant happened starting 2011, which is the demographic shift with the influx of refugees, especially from Syria, resulting in the fact now that we have approximately 1/3 of our population being refugees, resulting in the highest refugees per capita in the world, which by itself is a challenge for any country. Add to that the healthcare system before that was doing relatively well, but based on the needs that we have as a country. Add 1/3 of the population to that, and automatically in any country on the world, the system will sort of become fragile. Next, please. So basically, as part of our work with RUHF, we had 2 tracks, one track on NCD and another track on mental health. This is the work that we have been conducting with colleagues in Lebanon for the past 2 years. Today, we will be focusing on the mental health component, specifically on a couple of studies that were already published. The first one looks at the dynamics of access, utilization, and delivery of mental health care in contrasting fragility context in Lebanon. And when we say contrasting fragility context, we decided to do something that is sort of to give us a better insight on what's going on in Lebanon. So we selected 2 regions. The one is Beirut, which is the capital of the country, and another one is the Biqa region. And they are contrasting because of 2 reasons. Beirut, being the capital, has a high density of the population, has a better healthcare infrastructure, but the concentration of refugees to population is less than Biqa, which tends to be more, a little bit more rural, and had a higher influx of refugees being on the border with Syria, and at the same time being mostly rural, results in a lower infrastructure of services in that specific region. Mental health in Lebanon in general has been making strides with the work that has been done by the mental health program in the Ministry of Public Health. But again, having such an influx of refugees with all the history that comes with war and conflict definitely adds another layer of challenge to their whole operation. Anyways, this specific study had two main aims. The first is looking at community members and primary healthcare providers just to perceive some of the problems and the challenges and the approaches. And the second is looking at the health system's ability to deal with this with the burden of mental health, especially with the efforts that were underway to improve the mental health services. So this is the first study. Next one, please. Findings from the study, again, depending on the objective, was that the causes of mental health were a little bit different as perceived by community members and health providers. Definitely with the influx of refugees and the issue of conflict, there were definitely long-term effects of exposure to war and violence. There were concerns on constraints expressed by the community members in terms of family income and resources, specifically because of displacement, and that also was an important factor in terms of seeking and receiving mental health services. And the third is the whole gender dynamics that was also clear from our findings. Now, in terms, something interesting that we tried to do with the study is to look at the diverse routes for health seeking behavior, and that was mostly driven by the community members. Again, whatever cut we did to the data, it was clear that social stigma remains as a main influence, irrespective of the level of care. But the sequence was as follows in terms of health seeking. The first, obviously, the first circle of health seeking behavior was through the family and the close social circle. Then there was the second level, individuals trying to cope and using some coping mechanisms that are individually based. And this is where we saw the gender differences between males and females. And thirdly, and this is where the social stigma was playing perhaps a little bit of a bigger role, especially compared to the first two, was seeking care in the health systems and seeking professional care. Next, please. So the barriers for seeking support were quite a bit. One that definitely can be further addressed and worked on, and perhaps Rabia will address that, is the issue of lack of awareness of available mental health services. So this was something that was identified as a barrier, specifically in the Beqa region, which, as we said, is rather rural, and the infrastructure in general tends to be less than Beirut, which has better infrastructure. The cost of services, although for many mental health services, especially those based in primary healthcare services, are relatively financially accessible. And the fourth is the whole mistrust in the quality of service. And this is a theme that we saw in this paper as well as in the other paper. All of these were barriers or delayed seeking professional treatment specifically for mental health. Next slide, please. from a health system, so this is the other study on patient-centered care. So for the patient-centered care study, we wanted to see what are the facilitators and barriers to moving in more of a, rather than patient, perhaps also a person focused care. And the things that the barriers that we found is that there was, at least from the analysis that we did, mostly qualitative and GMB, the lack of cohesive and coordinated management information system. The second is limited human resource capacity for mental health. And again, it's important to note that the program at the ministry was doing quite a bit of training, but things perhaps the challenges were happening at the same time as they were gearing up. And the third is the limited service integration and coordination. Specifically, and I know that this is an ongoing struggle, not only for Lebanon, but for many countries in low and middle income, most low and middle income countries, especially in conflict settings, is where you have to really put an effort to try and integrate mental health into the health, sort of the routine healthcare services. In our case, primary healthcare as a very good entry point. The facilitators were health professionals perceive mental health and physical health as being interrelated, which was a very interesting finding and a maturity and sort of how they viewed this. The healthcare providers were ready to build that trust and open relationship with patients. However, this may be a barrier or a facilitator number 3, which that healthcare professionals or providers were concerned with the evolution of people's experienced health problems, meaning that they were a little bit concerned about what would be coming in terms of health challenges. Remember that this is a study where the data was collected in the last period, and Lebanon specifically was and still is facing many challenges. So the expectation was that there would be additional needs, both specifically on mental health, from a mental health standpoint, but also from a physical health standpoint, which actually is the case, as recent studies have found. Next, please. So our recommendations, basically based on what we have found, is that the good part is that all of those challenges were comparable to those reported by the Lancet Commission on Global Mental Health and Sustainable Development. And definitely, although quite a bit of progress has happened in the mental health agenda, I think it is our responsibility as healthcare professionals to support those advocates within the ministry and within the community to continue to sort of support the efforts and establish an agenda that is supported both from an infrastructure as well as from a financial standpoint. Specifically, integrating mental health care with the universal healthcare coverage or packages that have been advocated for and implemented in Lebanon is definitely something that would be more needed. Secondly, strengthening the public awareness and also reducing the whole issue of stigma and discrimination within the communities. I think this would be a great facilitator for the use and access to mental health. And also, as is the case with most services, trying to enhance budget allocations for mental health in Lebanon in general, especially the work that is being done at the level of primary healthcare. Next, please.
Thanks ever so much, Shadi. That's really helpful. And I wanted to emphasize to people that Haja and Shadi have just given a brief glimpse of much of the work that's going on, particularly in terms of interventions and strategies. There is current work very much building on the scoping work that we've described, and really admire Shadi's team and Haja's team for the work that they've been doing in quite difficult circumstances in rolling out interventions or evaluations of current programs that are trying to respond to some of the challenges of the fragile context they're dealing with. Given the time, I want to move, I think, straight to Reynolds and to Rabia, because this work is very much meant to be, although of course academically sound and developing our broader conceptual understandings of mental health and NCDs, the two things we've focused on in both settings. We just gave a particular highlight of one in one and one in the other, but we're both working on both of those themes in both countries because of the importance of the continuity of care that is required for those challenges, those illnesses, but also the challenges of providing continuity of care in a fragile setting. So we're interested in that conceptual analysis, but very much want to have that as having impact on practice and policy. So we're very delighted first to pass over to Reynolds to reflect on the work and its impact and its potential impact in Sierra Leone and the implications of that work. Reynolds, over to you. I'm just checking, Reynolds, you can hear us? If not, I'm going to go to Rabia first.
Yeah, sorry, Alistair, it
No
was
problem.
on mute.
Okay, on you go,
Yeah,
Reynolds. I've lost your sound again, Reynolds. I'm going to go to Rabia just to see if we can sort out your sound or your vision, and I'll come back to you in a few minutes. So, Dr. Rabia Al-Shamai, if I come to you, with very much the same question for your reflection on, obviously particularly from the mental health perspective, but not just the implications of our work, but the broader understanding of fragility in the context of Lebanon at this time. Over to you, Rabia.
Thank you, Alistair. Thank you for the invitation for this panel, and thank you, Shadi, for the very crisp description of the situation in Lebanon. I mean, you're one of the persons who know most about the mental health systems in Lebanon and their complexity. And it is the same also for mental health in many ways. But before maybe going into talking directly about mental health, just listening to everyone, I was thinking about fragility in itself and how do we define it globally, not only in the sense of a health system or mental health system. And for me, a simple definition would be when our resources to cope are overcome by the stressors that we're facing, that our structures and systems are not working as they should be. And in that sense, I think COVID-19 made it very clear that in one way or the other, all of us are very fragile and all our health systems have their own fragilities. It's like the black swan that Nassim Taleb talked about, the COVID that came and erupted and changed the world as we know it, and just kind of reminded us that fragility actually in a way is the reality of our human existence. And I think there is a spectrum for fragility, and not everyone is fragile the same way or at the same level. And for Lebanon, just as a little background, Lebanon is a small country, about 4 million people with 1.5 million refugees, with a long history of political unrest, civil war, and in a region of the world that's quite unstable currently. And based on this instability, in the last year, we had a very important political crisis that's still ongoing, a very big economic crisis, then COVID at the same time. And in last August, we actually had one of the biggest explosions, non-nuclear explosions worldwide that decimated half of the city. So that's the background on which the health system in Lebanon is working, and more specifically the mental health system. And as you may know, usually in even developed countries, mental health systems are a bit behind. And in Lebanon, it was before 2000 based on big psych hospitals outside the hospital, outside the city, and the private care being in the one taking the lead when it comes to ambulatory care, psychiatry, psychology, and no integration in mental health, no community mental health centers. The law was outdated, the budget not enough. So this was the background on which the National Mental Health Program started working in 2014, building on the humanitarian momentum of the refugee or of the Syrian crisis response. And what we've been working on since is really revising the laws, the regulation, creating coordination mechanisms, governance mechanisms, that under the section of leadership and governance, but also focusing on scaling up and reorienting the services towards integrating mental health into primary care, developing community-based mental health services, building the capacity of professionals on evidence-based psychotherapies in line with WHO framework and in line with also human rights. In terms of prevention and promotion, we run campaigns. We're working with the Minister of Education. We were actually not, because of the lockdown and the situation with COVID, things became very difficult. We've launched a hotline for suicide prevention and emotional support, and we've developed the platforms for mapping available services. So people, if they are in severe distress, they can call the hotline. There will be someone to speak to them to try to de-escalate, and if they need services accessible through the network of the ministry or our partner NGOs, they can access that. In terms of research, we're trying also, as you've seen with the example given by Shadi, and within the project with Alistair, is to guide research toward informing the policy, and trying to really either validate our direction or at some time change it if informed by the results of these research. And the funding for all of this so far has been relying on external funding, not from the government. The idea was the project law for mental health that is now in the parliament sitting for about 2 years and a half, stipulated a budget for mental health, a governmental budget, but this never happened yet. And in a way, all the reform is right now relying on external funding, which ironically proved to be a good thing right now because of the economic crisis. We're able still to continue the work through our partners and through our networks, building on research projects, but also other specific service development projects with many of our local and international partners. So I'm going to specify 5 points that are helping us navigate a bit this fragility. One is having a very effective central body for mental health at the Ministry of Health, which is the National Mental Health Program, coordinating the work. Second, having solid coordination mechanisms in place with all actors and stakeholders. Third, having a clear strategy. So when the program was launched in 2014, we've developed a 5-year strategy that now we're reviewing to extend for the next coming 10 years. Fourth is adopting a collaborative governance model where everyone is included, everyone is partner in the decision-making and in the implementation. And fifth is using emergency to really steer any intervention towards system strengthening and avoiding building parallel system. We did this initially when responding to the Syrian crisis in Lebanon, but also we did the same with COVID and the same with Beirut blast mental health and psychosocial support response, where what we did was mainly develop an intersectoral action plan with 6 UN agencies, WHO, UNICEF, UNFPA, UNDP, UNHCR, and IOM, and all the actors in mental health in the country, where intervention we're aiming at the same time to respond to the people affected, but also to strengthen the systems in place and to push forward, for example, even more the integration of mental health into primary care within the THC centers that were affected and are now under renovation in Beirut.
Rabia, I think at that point, I want to go back to Reynolds just to have some input there, but can I just reflect on one thing of those 5 points? It seems that that's quite resonant. You would be agreeing with that idea that we flagged early on about governance and coordination as a key principle. I'm hearing that in many of your 5 points. And then also your earlier examples around the phone-in service, etc., also very much around trying to get accessibility and reduce barriers of mistrust and uncertainty. So I'm hearing some resonance with the framing we presented earlier, and I just wanted to check with you, is that fair? I mean, do you see that those are key issues? That's what I'm hearing from what you're saying.
Actually, I think you've got it right, Alistair. Specifically, the role of governance, I would say, and the role of ensuring that the governing body is really doing a good job and has the trust of the partners and the trust also of the service users themselves. But I guess also, I think it's really what's really important, and what I think is the last message that I would like to get across is when we look at the COVID response internationally, which put us all in a fragile situation, we're not all affected the same. And I think 2 important variables that come across. One is how strong or not the governance is, or the government, but I would say the governance. And 2, the values and the choices that the government made, whether into investing in the mental health system or not. And I think now the big questions in terms of fragility, if you really want to tackle, is are we ready to take on the 2 big questions that are actually making us most fragile, which are we going to address social justice and climate change? Thank you.
Okay, thanks, Rabia, so much for that. Some big issues there. Reynolds, it's great to see you. I can see you on the screen and we can hear you. So to hand over to you, and the similar thing that we were asking Rabia to reflect on the work, but also the contention about dealing with fragility and how that might become a useful tool for framing the challenges that you're facing in Sierra Leone. So over to you, Reynolds.
Yeah, thank you very much, Alistair, and all for organizing this. Yeah, I have actually been part of this this project, Fragility in Sierra Leone, just trying to have a sense of what the situation is actually in Sierra Leone. So, you know, over the past few years, you know, going through the districts, speaking to various community stakeholders, we did come up with a sense of what the situation is, the breaking trust between either the community members and the health facilities and the health-seeking behavior of people, you know, but, you know, trying to look at what we observed then compared to what has been happening recently, especially during this outbreak, this pandemic. We've got to realize that the system has really been fragile. You know, there was a point I went through different facilities to see what are the services that are available for NCD services in various health centers. You know, it is very sad to know that during this outbreak, there's virtually been no services for NCDs in Sierra Leone. I went to the key tertiary hospitals, you know, the secondary hospitals. They will tell you that NCD services are currently not available. You know, so that was really touching. And in fact, we did a lot of surveys just to kind of see what the situation was, you know. But I must say, as a government, as a Ministry of Health, there's been a lot of work right now to try and see how best this can be resolved, how these issues can be addressed. You know, like Dr. Wuri earlier said, we recently launched this the policy and the strategic plan for NCDs, but also we just a year ago launched the Commission for NCDs and in other words, Non-Communicable Disease and Injury Commission, because we are now looking at NCDs, you know, in the context of as a poor society like Sierra Leone, because normally we talk about the 4x4s, that is the cancers, the diabetes, the COPDs, and this issue of hypertension. But now we are recognizing that there are other NCDs that are affecting this part of the world, you know, and of course, added to that is the issues of injury, you know, with the change in modes of transportation. Like in Sierra Leone, we now have all these Okadas, and so you find out there's a lot of cases coming up with accidents and so on. You know, so there comes the setting up of this commission, which is actually the umbrella, in other words, the governing body for NCDs in Sierra Leone. So from this strategic plan and policy, we'll be looking at different areas, and one of them is this that relating to governance, leadership. Yeah, we find out most of this condition, I mean, apart from having working to establish you know, services, treatments, and so you do have the important element of policies that will support whatsoever activities that we're doing, especially that of reducing, first of all, the prevalence, and I mean that relates to the area of the legal framework, you know, that will help to reduce the risk factors for NCDs. So for that, say like for the area with support of WHO, we're working on this framework convention on tobacco control. We're working with different stakeholders when it comes to the issue of alcohol abuse and so in Sierra Leone, because you know we've come to the realization that these products, say like alcohol and tobacco, are very cheap in Sierra Leone and produced, of course, locally. Although like cigarettes is nearly imported, but with these legislations, we hope, you know, it's actually a key, you know, to addressing issues of NCDs. But you know, we have come to the realization that legislation alone is not going to, you know, solve the problem. You see, there is this issue of, yeah, no matter how you educate the public, there is still a possibility of, because of peer pressure, so especially the youths, increase their kind of choices when it comes to taking up alcohol and tobacco. So there's this area of taxation that the Ministry of Health has also been pushing, and this we've been working with the Ministry of Finance to come up to kind of increase taxes in this product. So in fact, at the moment, we already have regulations that have been drafted and to be submitted to the Law Officers Department to increase taxes in these products, because we do have agreements within ECOWAS to have a minimum tax structure for these products. We are also working with the Ministry of Finance and the National Revenue Authority to come up with excise tax stamps, you know, which would help us to monitor the importation of tobacco products and also alcohol products that come in country. We are looking at how best we can address the issue of illicit trade in these products, and also see how best we can come up with penalties for people who break the law. But
so Reynolds,
there is also the issue of, yes, hello.
I was going to say, I'm just aware of time, and we probably need to transition just to this broad open discussion.
Okay.
I wanted to flag one thing, which I thought was really important that you had said. So I think it's really encouraging to hear those examples of quite high level government commitment and governance in terms of law, which Rabia had also pointed at in terms of mental health legislation for you for NCDs. So I think it's that governance area in context of fragility is clearly important. But just to flag, and I know you've been a great supporter of the social mobilization work, of the scaling up of the desk guide, supporting frontline health workers dealing with early diagnosis and management of NCDs. There's also that important, I think, development work in the setting, which I wanted to thank you and ministry colleagues for promoting the scaling up of sort of practical, local level primary health care and community focused intervention. So it seems again that there's the two sides of that are complementary in your work. Is that a fair representation, Ren? I just want to check with you, and then I want to hand over to Karen for the last 15 minutes or so.
Yes, oh sure, that is a fair representation, yeah.
Okay, so you'll have caught some of that for people that are joining us. Some people are joining and leaving and so forth, but Haja Wuri earlier on was outlining some of the research-focused developments, but very much in collaboration with the Ministry of Health in terms of scaling new interventions at a local level and supporting primary health care, prevention and control work. Karen, I want to hand over to you for the last 15, 20 minutes. I think we started a little late, we could probably over a little bit, but I'll let you flag the Jamboard discussion, and then I'll look out for any other questions that are coming in on the discussion page.
Brilliant. Thank you very much, Alistair, and thank you to our speakers. It was really great to hear from all of you and to our discussants as well. So I just want to draw your attention to all of those in the session. In the discussion forum, there is actually a link to a Jamboard page, as Alistair says. I would urge you to please go, if you want to actively participate, to go and copy that link basically into your browser and open the Jamboard, as Julia is doing right now. So she has it already open. I'm going to wait a couple of seconds for you to join. As you see at the top of that page, there are a couple of you. One is a cat or a kangaroo, I can't really tell. But the Jamboard is just basically our way of trying to get your views, even though the meeting is actually set up for you to be able to chat. So we're going to monitor as we go along. Yep, I'm going to wait just a couple of seconds. I see a couple of you are joining. Yep. Just going to give you a couple of seconds. You can also just watch. So I think our first question that we really wanted to pose to the whole group who's either listening or who has spoken today is reframing fragility necessary? So we have obviously embarked on this journey to try to move away from a pejorative term to something more analytical, to something that allows us to identify where and how to intervene, to strengthen systems, but also to strengthen, like Dr. Rabia was saying, social justice, and to try and actually achieve better health and well-being. So my first question is really, do we have to do this? Is it necessary? And what could potential advantages be? And you see on the Jamboard to your left that there are little, underneath the little mouse icon, there is sticky notes or other bits. Yes, thank you. That's a great way to start. So just please add your thoughts to the board itself. So one thought we have is we're stuck with the term, we should just make best use of it. Yep. Do we, whoever's putting that, do we mean the traditional use, which was very much fragile and conflict affected states, or should we just reorient it? What do we think? I'm waiting for other people to please put up some lovely sticky notes. What are potential, if we do make best use of it, what kind of use? Is it the way we've done it, or do you think that we should move into a different kind of direction? Again, just please put your thoughts. Oh, there we go. By reorienting or clarifying. So that's great. Whoever put that one down has clarified. Any other thoughts? Perhaps the easiest to ask is, do we stick to the pejorative label? That's a simple yes or no if you wanted to. I can see there's only maybe 4 or 5 people on the Jamboard. So equally, if you just want to type into the chat, I'm sure Alistair can monitor that, and equally we can speak it up out loud?
Yeah, I will do. I'll note any contacts in the chat. And again, Rabia or
Reynold as well.
Reynold,
Yeah.
or colleagues may want to just chip in verbally or on the Jamboard.
What about if we do use the term?
If I may,
Go on.
Thank you, Alistair. So I think definitely from my perspective, fragility is not necessarily a negative thing. As I try to say that sometimes it's a good thing because it might also increase the flexibility. So just understanding it as a perspective and seeing how we can work with it can definitely make systems more agile and better to cope.
That's a great thought. Thank you so much. That's a good reflection, and that's very much kind of what we've tried to get at as well. Yeah, the label seems to put off some governments. Absolutely. Yeah. Yeah, that's great. So this is again to you. I liked fragility. Yeah, system structures are overwhelmed. Yep. In terms of, maybe we can take that comment where it says the label seems to put off some governments. I'm wondering, is that potentially a disadvantage of sticking with the term? So you see the second question down there is very much, even if we wanted to go for a reframing, what might the pushback be? And I can see the first, I mean, that might be what I would immediately think, that actually policymakers might not respond to that. Any reflections? We have more people joining the Jamboard, including what I believe is a penguin and a koala. So it's actually quite nice to see. Okay, just given time, I'm going to maybe, because we have only 10 more minutes, move to the second page of the Jamboard, if you wouldn't mind, Julia, to enable some more substantive engagement maybe on the thing that we actually were talking about. So a lot of our conversation has obviously moved to this idea of, okay, we're talking about opportunities that might happen or that might present themselves if there are particular risks that present. But then we also spoke, I think, across our speakers and discussants about different types of things that we actually need to strengthen or we need to work on. So this is obviously the framing that Alistair presented. I've tried to simplify it a little bit just because to fit it here. But if we use the term analytically, we had proposed these various variables, if you like, or issues. But thinking about your experiences, your settings, you know, are there things missing? Are there things that you would immediately want to put on this page for us to consider? Again, just please use sticky notes. Or equally, are there any links? So if you use the top button, which is just an arrow, oh, very, very nice. Somebody's already starting. So community trust in institutions and governance, is that something that's very important? It seems to have emerged from all of us. But any others equally, please feel free to add. Capabilities and resources. Okay. Okay, perfect. Thank you.
I'm just wondering, Karen, whether it would be also interesting to include a variable that is a bit outside
Absolutely.
the health system per se, but I don't know how to frame it. At the level maybe of.
Go on.
At the level of. Yeah, it would go at the level of the political level of choices, the political choices, all in all, that are being made.
So I think you were saying earlier the orientation of the political choice, or the yeah, we can add that.
The government thinks that for example, mental health is a priority or is not a priority, or whether they think that climate change is a real issue or just.
Or do we not? Yep. Okay.
And just to note on that, Rabia, we haven't drawn much attention to it. That little blue line that runs along the side about, it says global and regional actors, ideas and interests. I think that's very relevant, particularly in your region, that
Yes, willingness.
it's not just a single government's response, is it? There's a whole context there of ideas shaping the political climate for addressing things.
Exactly.
Yeah. No, absolutely. And it's again, like we were saying, the priorities that they might bring or the interests.
This line can be a bit more, maybe in a way, developed or conceptualized a bit more.
Yeah, no, that sounds very interesting. Thank you. And somebody's playing with color, which is it's quite delightful. So
Karen, also,
go on.
if I may as well, also from an analytical standpoint, the economic aspect of it is rather interesting in terms of that political commitment has to be translated into some sort of an economic investment, right? I see somebody has put corruption in this, so I would include corruption, both political and economic as well. You know, saying something is a priority, an example, mental health, without really investing in it is also room for an analytical, you know,
to look at it more,
more analytical analysis on whether it's really a priority or just this is just lip service.
No, that's very interesting. Thank you very much, Dr. Saleh. Yeah. So again, the kind of the financing of it, do we actually invest in it? How do we invest in it? Maybe, corruption seems to have moved. Oh, okay. Just to more, maybe a risk. Okay, that's interesting. Yeah, very nice. Okay, we can acknowledge that as well.
It's just one comment. It's building on Shadi's and Rabia's comment, which is, I suppose, the right-hand side of this is broader. We call it the system for health or the health system, but the context, the landscapes of risk is not just a quick nod to those factors. It is a real dynamic interplay. So, for example, the environmental risks, Rabia, that you pointed to a couple of times in terms of climate change are very real, and that's not just a word. It's a real force in those arrows shaping what's on the right. Clearly, the economic circumstances and the political circumstances shaping that. So I think that's what we're trying to do, to draw from the OECD's framing of those landscapes of risk. I found a little bit of a hard concept to get my head around, but I think it's sort of right that it's how it lays out the land in which the health system is needing to operate. And both you and Shadi have pointed to very big risks or very significant landscapes that shape what you can do in the country at this moment. And they're captured by some of those dimensions listed there.
No, absolutely. And you've captured some relationships that are quite key, right? So the idea of how do you finance, how do you invest, those, we could draw those onto here. So that's very relevant as well. Are there any other things that you think are immediately apparent? I'm very aware we're almost at the end of our session, but it is just a question of, we're touching a lot maybe on the kind of the left-hand side, maybe a little bit in the middle, but what about the other side? We've kind of put these normative goals in there because we believe in them, but obviously, are there things that you think we should emphasize further?
In terms of language, I think it's important to I mean, we're talking about equitability, but I think it's really important to have social justice.
Perfect, yes.
Even though we're saying the same thing, but I think
it's the actual wording. Yes, no, I very much agree. Yeah, that's a very nice terminology. Thank you. Yeah, informal providers. All right. Yes. Yeah, absolutely. And a lot of our work has actually tried to focus more on informal providers. So that's a great place to also put that. Brilliant. I'm going to maybe close on a topic. So obviously, as a research group, we've spent a little bit of our last 4 years, it's not a little bit of time, looking at this, but are there particular things you think in future we should orient this kind of framing towards studying? So if you maybe want to add other post-it notes on, it would be, I think I've heard already, we should maybe look at, okay, the financing, we should look at the priority setting, maybe informal providers, but are there any others that you think this warrants research in terms of this analytic framing of fragility?
I suppose I'm particularly mindful in terms of that question, Karen, of what is already happening in Lebanon and Sierra Leone as a result of this sort of engagement. So the influence is maybe subtle, but so Reynold, I mean, you can elaborate on this, but the fact of your close engagement through that 4 years means that in meetings about planning the policy on NCDs and in supporting the national scale up of the desk guides to support primary healthcare development, it's sort of a research topic that's found its way into policy, but it's been such a close relationship that I'm not sure we would just draw a single arrow. The fact that the ministry was helpful in developing the research agenda for us in Sierra Leone makes it part of the way of policy deliberation. And I sense also, Rabia, I'm perhaps inviting you to comment on this, not just in terms of collaboration with AUB and Shadi and others, but more generally the research climate in Lebanon in recent years, the extent to which do you feel you've managed to co-opt and establish partnerships in a way that have been helpful rather than distracting? Sometimes researchers get a reputation of not being so useful at a time of crisis. I suppose I'm asking you, Rabia, just in a concluding comment, the extent to which research engagement in mental health in Lebanon over the last couple of years, the balance between it being a helpful engagement or it being a distracting and not so useful one.
Thank you, Alistair. We've been very, very fortunate. We have about 7 research projects. All of them are geared towards our priorities and towards our strategies, and are helping either build or research areas that are important for us. So in that sense, we've been very, very lucky. And here also maybe another note that might be really important, Alistair, either in this framework or in general, another factor that I haven't mentioned, and I think in a way I've been taking maybe not relevant to this concept, but I think one important thing is the strengths of the national and international network around the work being done. I think this also can either make fragility from an analytical point of view more hazardous or less hazardous, because fragility sometimes, for example, increases the interest in research and how you can use research to actually help you do the work you want to do. So the national and international network, I think that would go in maybe in this vertical line.
With the global and region, absolutely, yeah.
That's really helpful, Rabia. Yeah, and in terms of that, I think many of us within the research unit, but I think broadly within the NIHR sort of stable of projects, is looking for a sort of an international solidarity and cooperation of that nature. So it's good to hear that's worked well for you. We're 2 minutes over time. We started a little late, but I'm aware that people have other schedules and other things. So thank you so much for joining with us. Thank you so much to all of our speakers, not just for speaking today, but for their strong engagement, either as research colleagues or as policy colleagues that have really been champions for the work for us. We have in the note there the resource list of some of the papers that we've published in the last year or two that are relevant to this. And I think if you go to the last slide, there are sort of contact details. If there's anything, if you send any queries to us, we can direct it to the relevant grouping, whether it's Shadi or Haja or colleagues of us in here in Edinburgh. So thank you for your time. Thank you for colleagues, Francois and others with Health Systems Global in enabling this to happen. And we thank you for your time and reflections with us, and pray that you might work with us to build systems, health systems that can cope with the fragilities that the world is currently and continues to throw at us. So we thank you for your engagement and enjoy the rest of your day. Thank you.